This is EM Pulse
with your hosts,
Julia Magana
and Sarah Medeiros. Welcome back to EM Pulse.
Okay, Sarah, we're back again talking about little ones with fevers, one of our pediatric dilemmas here. You know, Sarah, I grew up doing LPs on so many babies with fevers, and now we have better information, new databases, new vaccines, improved testings. We're just getting better and better at knowing which infants actually need that LP, that invasive testing, and which ones are at risk for invasive bacterial illnesses such as bacteremia. This next study in the evaluation of the febrile infant is a real game changer in this topic. This article is called The Prediction of Bacteremia and Bacterial Meningitis Among Febrile Infants Aged 28 Days or Younger, and it's published in JAMA. It's hot off the press and really answers a lot of questions many of us have had for years in that first month of life. Primarily, it answers the question, how accurately does a clinical prediction rule based on urinalysis, procalcitonin, and ANC identify febrile infants at low risk for bacteremia or bacterial meningitis?
Yeah, and to help us answer that question, we are here with our EM Pulse frequent guest, Dr. Nate Kuppermann. He's the Executive Vice President and Chief Academic Officer and the Chair of Pediatrics at Children's National Hospital in Washington, D.C. And with our new guest, Dr. Brett Burstein, who's a clinical scientist and pediatric emergency medicine physician at Montreal Children's Hospital at McGill University. Okay, we're going to mix things up a bit here, and let's start at the end. Brett, what is the bottom line message of this study question?
I think the bottom line is that this study can help us have better perspective than we ever had before on what we've been trying to investigate for over 40 years, and that is how to identify febrile young infants in the first month of life who are at extremely low risk of invasive bacterial infections. So what this study found was that in a large international pooled sample, that the PECARN Rule, published in 2019, performed extremely well for identifying infants who have invasive bacterial infections. So it had a very, very high negative predictive value for ruling out all invasive bacterial infections, and in particular, there were no missed cases of bacterial meningitis.
Okay, really helpful. Good spot to start. But let's do a quick reminder of terms. What is serious bacterial illness and what is invasive bacterial illness?
It's a good question. So historically, we've talked about infections that febrile young infants are at risk of, and that became more commonly known as serious bacterial infections. The three main infection types we've been targeting for years, that is the UTI or urinary tract infection, bacteremia, or bacterial meningitis. These collectively became known as serious bacterial infections. But what we've known for about the last 10 years or so is that the urinalysis performs very well with very good diagnostic accuracy for diagnosing urinary tract infections. So really for about the last 10 years, the research is focused on identifying infants at risk of the most dangerous infections. That is the invasive bacterial infections, just bacteremia and bacterial meningitis.
In medicine, like life itself, we try to make things simple. So we have that term, serious bacterial infections, as Brett described, to kind of combine all three of these infections. And then we realize, UTI is probably not as important as bacteremia and bacterial meningitis. So then we created that term, invasive bacterial infections, for those latter two. But actually, in the last several years, we realized, bacterial meningitis is not the same as bacteremia. It is much more serious. So in fact, as we study these infections moving forward, we really should be talking about each of the infections separately because they are each very different.
So we've podcasted before on this topic, and the PECARN Febrile Infant Tool suggests that a child 0 to 60 days of age is low risk if they have a negative UA, ANC less than 4,000, and procalcitonin less than or equal to 0.5. That rule was prospectively derived and validated on over 1,800 infants in 26 hospitals across the U.S., and they found a 99.6% negative predictive value. But it only evaluated 555 infants 0 to 28 days. Subsequently, the AAP created a 2021 clinical practice guideline that gives some recommendations on how to approach the febrile 7 to 21-day-old infant who has a fever and is well-appearing without an evident source of infection. So they suggest you obtain a UA, blood culture, and perform an LP, and you may obtain inflammatory markers such as CRP and procalcitonin and ANC, but they suggest that all infants have a complete sepsis workup, receive antibiotics, and are hospitalized. They also recommend evaluating for HSV if there are risk factors. So this aligns with what we've been taught for more than 30 years. And this current article really proposes a new way to look at this, as we heard from you at the beginning.
Sarah, you spoke just like the scientist you are. And when we created the original rule in 2019, the PECARN Febrile Infant Rule, you're absolutely right. It was about 1,800 infants that we derived and validated this prediction rule, but only about a third of the infants were in that first month of life. So even though the rule perfectly identified every patient with bacterial meningitis who had it, including those in the first month of life, there just weren't enough of those infants in that first month of life for us to feel very confident to push the implementation in that age range. So back then, what we said, hey, follow this rule in the second month of life and, sort of be aware of it in the first month of life. But we weren't saying to act on it because there weren't enough data. And that kind of fed into the AAP guidelines. I wasn't the lead author, but I was among the writing group and was involved with that for over a decade. And the data at the time suggested to us that we probably shouldn't go super aggressively in that first month because there were insufficient data.
So tell us a little bit about why this study is different. Tell us about how you derived those conclusions.
When Nate first presented follow-up data, this was an external validation that had been conducted after the publication of the original PECARN study. He presented at the AAP in 2021, and I was on the Canadian guideline writing committee for febrile young infants. And we were pretty compelled by the amount of data that the PECARN group had amassed. And we had other pragmatic considerations. It's a very big deal to transport infants across the great distances that we have in Canada. So we knew there was a very important implementation component. We actually already introduced this approach even at that time. So we were quite compelled already with that amount of data. But we knew that to have more comfort and be really comfortable with making recommendations in the first month of life, it was going to take really a collective international effort. And so, as Nate mentioned, there have been groups that have been studying febrile infants really all around the world for many, many years. And we here in Montreal had established a very large prospective cohort, and we had made relationships with these other groups studying from around the world. And we reached out to them and said, listen, if we're going to try and study this and have more definitive data, it's really going to require that we pool our data. And that's really the genesis of this story. So we reached out to our collaborators in the UK and Ireland, across Spain. We have not only the step-by-step group that we're participating, but also the single center from which it was originally derived. And it was only when we put it all together that we were able to amass a total of 2,500 infants. So this is huge. If you think about the original PECARN publication, it had just 555 infants in the first month of life. So this is a really large number of infants. Our primary analysis excluded the infants from the PECARN original derivation and validation cohorts so that we wouldn't introduce bias, but we found really the same study characteristics. And when we look overall, in all 2,500 infants, there were no missed cases of bacterial meningitis. So we thought that was really, really compelling evidence. And that led to the conclusions and sort of our recommendations that came in this publication.
So you put together this database from several countries, many different hospitals, all 0 to 28 days, and then you validated the tool inside of this database. Is that a fair summary?
It is. I mean, it's sort of an external validation of sorts. We're really looking specifically at the diagnostic accuracy, and we did it using sort of meta-analytic methods, so really robust methodology. And we took sort of commonalities between all of the cohorts to be able to compare them. And, we were really compelled with the results, being able to say that this is a very, very high-performing rule that can safely exclude those infants at risk of invasive bacterial infections.
Okay, great that we have a large database of this exact age group, 0 to 28 days. What did you guys actually find? How good is the PECARN Febrile Infant Rule?
So the primary analysis of this study included the 4 international cohorts without the original PECARN derivation and validation cohorts to not introduce bias. And the rule performed very well with an exceptional negative predictive value of 99.4%, and it missed no cases of bacterial meningitis. So it was just cases of bacteremia that were missed. And when we then include the PECARN data, we have over 2,500 infants. And again, the negative predictive value was 99.6%, and again, did not miss any cases of bacterial meningitis. I like to compare that and put it in terms of when we think about how many LPs would you need to perform. So a number needed to LP. So that would be about 2,000 LPs and possibly as high as infinity to be able to identify a single case of bacterial meningitis. What this also tells us is that that level of risk is really extremely low. How low is it? Well, if you're familiar with another rule brought to us by the PECARN group, that is for blunt head trauma, which children should have CTs of their head to not miss death, ICU, or neurosurgery, well, that rule also performs with a negative predictive value of 99.6%. And that would be to have a family be discharged from the emergency department with reassurance. So we're talking again about a high-stakes outcome. That's the number needed to test. And when you meet low-risk criteria by these PECARN rules, what we recognize is that the risk really is extremely low.
There's an emphasis here on bacterial infection. So Nate, going back to what you were talking about, where does HSV fit into this?
Herpes, I think, is a very interesting story because herpes in its own right is a very important and highly risky infection to young infants. And there are their own risk factors for HSV, and they're delineated very clearly in the AAP guidelines and elsewhere. But the fundamental question is, because we're proposing this new approach to not routinely do the lumbar puncture in this first month of life based on the PECARN rule factors. But the question is, by not doing the LP, are you somehow going to miss some HSV? And really, if you kind of put it in other words, simpler words, is that how frequently is the only way that you diagnose HSV by the LP? And the answer is not very frequently. So what we did is that we looked at, first of all, the overall risk of HSV in febrile infants in this age group. It's probably all comers. It's about 1 in 600. But the question is, of that 1 in 600, how many of them actually presented with, history of maternal vesicles or skin rash, ill appearance? A lot of them don't even have fever. That's not necessarily a hallmark of HSV infection. So when you kind of slice and dice it down to how frequently would the only presentation be on a positive LP without any other historical or physical findings of herpes, it may be 10 or 15% of those. So now the risk of HSV just by the LP is not 1 in 600, but it's more like 1 in 4,000 or 5,000. I'm rough. This is back of the envelope calculations, just to be clear, because there are no prospective studies around HSV. This is based on retrospective data, so you don't know how they look. Of course, a highly ill-appearing infant would not appear in the PECARN rule, that kind of thing. So back of the envelope, we're talking about 1 in several thousand for HSV, and we're talking about 1 in, at a minimum, a couple of thousand who, if you're low risk by the PECARN rule, who would have bacterial meningitis if you did the LP. And now that trade-off between 1 in several thousand versus the risks of the LP is a conversation to have with families.
I'd like to add something to what Nate just said. Andrea Cruz is probably the foremost expert in the emergency world on this subject, and she was the lead author in a publication in 2019 about a rule to be able to identify infants with invasive HSV. So we reached out to Andrea to be able to get some perspective on this, and what she was able to tell us is about 80% of the infants who had invasive HSV were ill-appearing, documented as ill-appearing even in a retrospective study. So this was one of the first points that she made. And of course, the PECARN rule is made to be applied among infants who are non-ill-appearing. So that's a first very important caveat and probably will help us basically drop that number with HSV even further. The other point that she made is that among the 4 infants that had CNS disease, 3 out of 4 of them also had an elevation in their transaminases. So that transaminitis as a simple blood test, even if you wanted to include that as a screening test, that also could help you further mitigate the risk of HSV. So the important take home here is that this rule was made to be applied among infants who are well appearing. And I think that can really bring down that worry we have about HSV.
It's important, and Brett rightly pointed out that the Canadian Pediatric Society, they came out with a different conclusion than the AAP. They did have a few more years of data gathering, but still fundamentally they came out with less conservative approach around LPing in that first month of life. But in fact, there's actually at least one group in the United States at Utah, at Primary Children's Hospital, their febrile infant guideline, which to be clear, they published before our JAMA article was published. They said down to age 3 days, apply these inflammatory markers, similar to what Brett and I are talking about. And for herpes, they say separately, make sure there's no risk factors for herpes. And if there is, pursue aggressively. Just what Brett and I are saying. So now we have really compiled the evidence for people to have a good risk assessment on both sides. That is, we know what the risk of missing bacterial meningitis. It's not good. But now we also know what the risk of having meningitis or HSV amongst this group of febrile infants. It's uncommon enough to be able to have that legitimate discussion with family. And our guess is that the number of LPs in that first month could likely be cut in half based on these new data.
Okay, guys, so I am a general emergency physician. I see kids probably 2-3 shifts a month. Let's say I'm on my next shift and I have a febrile 9-day-old who comes in. Walk me through how I'm going to apply this.
First of all, I think the important thing is that we recognize we're talking about the right type of infant, and identifying an infant who's not ill-appearing is critical. We know that significantly increases the risk of invasive bacterial infection. So it's important that clinicians are comfortable identifying infants that are well-appearing. The second part is making sure that we don't have exclusion criteria, that these infants don't have other risk factors for invasive bacterial infections. So a known history of prematurity, a known immunodeficiency. These are examples of infants who are particularly fragile, but the truth is they've just never been tested in these cohorts. We don't know the rule performance in those infants. So it's important to know who to exclude. Now, I'm glad you brought up the point of someone working in an emergency department that doesn't see children frequently. It's very important because this means, as you know, there's an opportunity perhaps to not have to perform an LP. LPs are technically challenging and they're not always successful, particularly among physicians who don't perform them that often. So that is another reason why this approach would be game-changing.
People don't think about HSV that much just because it is a rare condition. So I would add in that 9-day-old, you'd want to be exquisitely careful that that patient doesn't have risk factors for HSV, which would be, of course, things like maternal infection, vesicles on examination, seizures, etc. That is really important because the peak age of HSV infection would be in those first 3 weeks of life. So I would completely agree with Brett's approach. They have to be, again, well-appearing, PECARN rule negative by definition, because that's what we're here talking about, and absolutely no risk factors for HSV. And then I would do shared decision-making, that this is a baby that I would be comfortable admitting, watching in the hospital, 24 hours. We know that over 90% of positive blood cultures become positive in the first 24 hours. So that would happen while the baby is in the hospital in that unlikely occurrence because they're PECARN rule negative. And that would be it. But I would do shared decision-making. And if the parents were more comfortable with doing the lumbar puncture, we would certainly pursue that.
I think that's one of the most important aspects of this study. So both the American Academy of Pediatrics and the Canadian Pediatric Society recommend shared decision-making with families. But to do that, you really have to have as precise an estimate of risk as possible. And that, I think, is one of the really most important things to come from the study. We know that families don't want their infants to have lumbar punctures. This is the single most anxiety-provoking aspect of the care for their infant. So when we start talking about risks and benefits, it's important that we can quantify what is the real risk. And now I can comfortably tell a family, we know what the risk is given that your baby meets our low-risk criteria.
It's interesting, Brett, talking about the tremendous benefits of this rule. And there's several. And probably the most important, what Brett said. And we know because Brett has actually done some of this work. Paul Aronson has done some of this work. Focus groups with families and parents. They don't mind having their babies admitted. They don't mind getting antibiotics. They do not want the lumbar puncture. So that's really important. That's being very patient and family-centered. But there's other things as well. We know that there's always downstream risks. There's risks of doing lumbar puncture. When I say risks, we get bloody taps, so we don't know what to do with that. We get failed taps, and now we've decided to do the LP, but it's unsuccessful. So then you need to go under fluoroscopy to do it. There's all sorts of problems with that. There have been complications noted by holding the infant inappropriately and causing harm with that. There's no such thing as a completely safe test in medicine. And the last thing I'll say is particularly for the community physician, emergency physician out there who doesn't see that many babies, nobody's skill set to do LPs in the first month is that great. And the good news is that this cuts that rate in half. And I know that means you're going to even lose more practice doing it, but that's a good thing, right? It's patient-centered, it's safer, and it's better for everybody.
Yeah, I definitely find that most parents would avoid the LP if possible. So I've got my 9-day-old and, they look fairly well appearing. 2-year-old brother has a URI. They have no risk factors for HSV. We've talked about it. Parents would like to avoid LP. So remind me now, what am I ordering and what am I looking for?
The recommendation is still that all infants in the first month of life have a partial sepsis evaluation. That is blood culture, urinalysis, and blood tests for risk stratification. The recommendation is to be using, ideally, a procalcitonin-based system like PECARN, so procalcitonin, ANC. Our protocol actually also includes an ALT for screening for HSV. Additional testing can be guided by the clinical scenario, whether you think you need additional testing for respiratory viral panel, a chest x-ray, stool studies. Those can be guided by the clinical situation. But really, it's the blood, urine culture, urinalysis, and risk stratification blood tests that are necessary.
And I'm going to add that really important two things Brett said is that we know that the CRP is a pretty good inflammatory marker, but we did not have enough CRP in this study. So this study can only be done with the procalcitonin. That is really important. And I like Brett's recommendation because I would do it as well. That is, I would add the liver function test, the ALT. I can't quote you the percentage of infants with systemic HSV who have transaminitis, but if that were positive, that's a child that I would aggressively pursue HSV infection.
Yeah, the data on ALT is just not as robust as other things. In Andrea Cruz's study, there just weren't enough infants that had ALT routinely collected. Among those that did have it collected, those with invasive disease had a transaminitis in 50% of cases. Those who had it collected and didn't have invasive disease only had about 9% elevation. So, it's like 5 times higher. It's a pretty good marker. There's no really good blood test, unfortunately. So we use it as a screening test. It's not a great screening test, but it's just about all we have for blood work. And that's why, as Nate pointed out earlier, it's the clinical history that's so important.
Okay, my approach to a 9-day-old that comes in with a fever, no known source here. I'm going to start with a good history. Mom's GBS status. Is mom sick at home? Does she have any HSV? Is the baby premature? How's the baby eating? I'm going to do a really good physical exam. And I'm going to look for those vesicles. It doesn't show up in even the majority of infants. And at 9 days of age, that's going to be rare. But I'm going to look at tone. I'm going to look at suck, put a glove on and let them try to pull the tip of my finger, glove finger off. I'm going to see how their urine output is. And I'm going to watch them in mom and dad's arms. That breathing, that heart rate, those are really important vital signs. Is there a good cap refill? Are they mottled? And it's not just because they're without their onesie and they have no melanin. And then for these kids, Sarah, I am going to draw blood work on everybody. The AAP says you don't have to because you're just going to go and do the LP. But I think now that we have this study, that is going to help me know that I do want a blood culture. I want a CBC. I'm going to look specifically at the ANC. I want procalcitonin. I have that at my hospital. And I want a urine. And, whether you do a bag or a clean catch or how you do that, I'll leave that up for another podcast you can find in our feed. And then I'm going to wait for that blood work to come back, but I'm going to start having that discussion, introducing the idea to family that we may need to do a lumbar puncture. Once that comes back, then my discussion with the family is going to be informed by this 1 in 2,000. But I think you also have to say that the American Academy of Pediatrics has different recommendations. And this article for me doesn't supplant the AAP recommendations. It should inform them in the future, heads up AAP. And it also allows me to have that more nuanced discussion with the family. And I can then have that discussion, document it, and move forward with it, admit to the hospital and watch all of these patients. I would watch them without antibiotics if I'm not going to tap them personally. But I think we have to recognize that this study is not an implementation study. It's a validation study. And those are two separate things. So it's a little bit hard to say exactly how you would apply this.
That is a really nice summary of how you would evaluate a 9-day-old infant. But I just want to make sure it's really clear to the listeners here, and you said it in your summary, we are not talking about doing the PECARN rule and sending a 9-day-old home with fever. That's really important. Even though we're confident in our numbers of not having missed bacterial meningitis, we did miss a few cases of bacteremia. It's still very uncommon. I think it was 0.7%. I think, Brett, if you're negative by the PECARN rule.
Lower, 0.5.
Yeah, so we still want to keep that baby in the hospital overnight, watching them closely. And Julia, you're absolutely right. These are different than the AAP guidelines, although the authors of the AAP guidelines, they're all colleagues and friends of Brett's and mine. They're aware of these, and they're going to likely be updating guidelines. And remember, there's already guidelines out there, like I mentioned, in Utah guidelines. Their guidelines say to do this down to age 3 days. So I am very careful not to call the AAP guidelines the standard of care. It is a standard of care, but like Utah, they have their standard. The Canadian Pediatric Society has their guidelines. So the most important point to me is that we present to families the honest evidence and what is the range of what is done. And Julia, to your point, absolutely. I would tell them about the AAP guidelines. I would tell them now about our pretty precise risk of having bacterial meningitis given a negative rule. Then certainly the risks of missing meningitis. All of this is fair game. But this now lands back into Brett's comment about like the PECARN head injury rule into a risk where parents should have a say, because there's no slam dunk correct answer. Really, it's based on individual values and risk tolerance and whatnot. And we've basically moved this from a slam dunk, you just do it, to the space where now we can talk about it.
I just gave a talk on febrile infants 0 to 28 days, and I've been giving it for years. And I said I picked this topic because it was always the easiest. And dagnabbit, now it's the most complicated.
Sorry to complicate your lives.
I like being able to give that perspective to families. If you tell a family, look, historically, we've always done this way. We want to miss 0. We have a risk tolerance of missing none. But now we know that we have a very good estimate. Your baby is low risk, and it probably means that we could defer this lumbar puncture. If a family says, well, what are the risks of missing it? And you say, well, I'd probably have to do 2,000, 1 in 2,000. In your experience at the bedside, what do you think parents are going to choose? We know that there's a difference between the way families and physicians perceive risk. But one thing we know, this is the procedure that they are the most averse to, that is the most anxiety-provoking. So I think being able to provide that number to families is going to be game-changing. And I think no longer having a conversation that just says, we just do this for everyone because we always have. I think that's really what's so game-changing about how you can have that shared decision-making conversation.
So I have a question. The procalcitonin is kind of a key piece here, and I can get that easily at UC Davis. But is that something that physicians can get everywhere? And what do you do if you don't have access to that?
Okay, procalcitonin, it's not like a 3D holographic PET scan, okay? In Europe, they've been using it for like 30 years. And, for many years, it's even been a bedside test. It's not expensive. If you don't have it, for God's sakes, just get it. I mean, really, that is the answer. That is the real answer, okay? Having said that, there are data, Brett and others, he and I together have studied how CRP works when procalcitonin is not available. But for this first month of life, I personally will say, don't do it. If you don't have procalcitonin, you can't apply what we propose here because you got to follow the research. And what we have proposed here is just a validation of the study that requires procalcitonin.
I would say for every physician who evaluates infants with fever in the first months of life, really they should have access to this test. And I think it's really a question of advocacy at the hospital level. What have been the barriers is unclear to me. It's not that expensive a test. We've actually done a cost modeling study, and we looked at the costs. And in reality, if you think of like a CBC costs about $2, and a CRP costs about $3 in Canada, and a ProCal costs $30. So imagine for a moment, like that's the cost difference we're talking about. And we know that the use of ProCal probably spares 10 to 15% of overall costs. And more importantly, the downstream consequences, the anxiety to families. So I don't know what the barriers are, but I think there's an important element of advocacy necessary to make sure it's in the hands of all those who evaluate febrile young infants. So unfortunately, the recommendations that were made in the AAP guideline that incorporate CRP, those had not previously been studied. So they made, consensus recommendations based on a bunch of studies put together. And our group was actually the first to study that combination of CRP, absolute neutrophil count, and temperature. So that is the recommendation from the AAP, what to use when you don't have procalcitonin. It was kind of a recommendation that made from expert opinion based on a bunch of different studies, but they had not ever been studied in combination together or at those thresholds. So our group was the first to study it. There have been some other studies that have come out subsequently, and that approach turns out is probably very safe, tends to also not miss any cases of IBI. The problem with that approach is that the specificity is very low, probably in the 30 to 50% range, which means that most infants are probably not going to meet low-risk criteria. The other issue is that you can probably do a little better than the recommendation that was made by the AAP, and Nate and I published together using the PECARN methodology, basically optimized thresholds. And it turns out that if you make small substitutions, you can probably do even better for the specificity. So I look to see what will happen in the next iteration of AAP, incorporating what to do when you don't have PCT. But to Nate's point, just get it, or advocate for it.
I love it. And I think we will all be looking out for updated guidelines after this. So thank you so much, Nate and Brett, for your work on this and for speaking with us today and taking us through it. I definitely learned a lot, and I love that PECARN continues to debunk these myths.
It's really an exciting part of our jobs, getting to talk with people like this and then integrate that into our own practice.
So thank you to our department for enrolling patients in this study.
And thank you to OM Productions for letting us do so many topics on febrile infants.
So until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.